first of all, I want to welcome everybody, and also we should thank God that we are surely here, and we should please mute those people who are shouting in the background. Thank you. So, Benja, can you give us a brief view about Busoga Health Forum before we our presenter this evening?
Yes, thank you so much, Dr. Kabweru. For those who are joining us for the first time, this session is brought to you by Busoga Health Forum. And Busoga Health Forum is an association of like-minded people. It's an NGO here in the heart of Jinja City.
Is it time to start now?
No, Doctor, not yet. I will tell you when we are ready. I'm just giving a brief introduction.
Hello?
Doctor, we haven't yet started. I'm just giving a brief overview of BHF, then I'll get back to you.
All right, okay, that's fine.
Okay. Okay, so for those who are joining us today, I want to welcome you to Busoga Health Forum, and this is our weekly webinar. Today's webinar is a bit different from the rest. We're having out of technology and to bring to you this session. So Busoga Health Forum is an NGO here in the heart of Jinja City, and we are working in collaboration with the Ministry of Health. We are working with civil society organization. We are working with DHOs. We are working with the formal and non-formal structures that will improve the health of the people of Busoga. We, among our program areas, we are having programs in Ramnak, that's reproductive, maternal and newborn health. We are having projects which are looking at non-communicable diseases, infectious diseases. We are also having interventions targeting urban health, because we are seeing that we are having out of urban development, but this comes with a lot of challenges that may hinder, but that may be a challenge to the health of our people. So we so much look at improve the health by looking at the challenges which are brought by the urban development. Among other programs that we look at as Busoga Health Forum, we have pro bono initiatives, and every month we run a pro bono clinic in Mafubira Center 2, where Dr. Yusuf consultant comes in to see that he gives free consultation to our people, but we also have NCDs outreaches that we do. So we also bring to you these sessions like Zoom to improve the capacity of health workers in the region. So we kindly request that you become a member, because we are a membership organization. And it is through your membership that we are able to sustain such activities. Membership is only 100,000 shillings for individuals for a full year. Lifetime membership is 1 million shillings, and institutions pay 500,000 for a year. That's the brief about Busoga Health Forum, and I want to hand over to Dr. Kabweru to make the introduction of the presenter. Over to Dr. Kabweru.
Thank you very much, Benjamin, for that elaborate introduction of Busoga Health Forum. Today, I want to take this opportunity to introduce our speaker this evening. My name is Dr. Kabweru Wilberforce, and I'm a senior consultant based at Mulago National Referral Hospital, and I'm also a bioethicist. So today we are having Dr. Claret Isabirye, who is a Ugandan, born and educated halfway in Uganda, and then decided to join UK, where he's practicing. He did his undergraduate training, that is the Bachelor's of Medicine and Bachelor's of Surgery from Makerere University, and also did his Master's of Internal Medicine, the same university, in 2002. And he decided to move to UK, and also he did other trainings elsewhere. He has a Master's of Public Health from University of Edinburgh, and a fellow of Royal College of Physicians of Edinburgh, and a fellow of Royal College of Physicians of Glasgow. And he is a member of Royal College of Physicians of Qatar, and is also a certified member of the Arab Board Examiners. is currently working and is a consultant physician in acute internal medicine, and is also working as a clinical instructor in the Weil Cornell Medical School in the UK. So I want to take this opportunity to welcome Dr. Isabirye Claret Charles to speak to you about chest pain, how you assess it and how you can manage it. Over to you, Dr. Isabirye Claret.
Okay. Thank you, Dr. Kabweru, for that brief introduction. You hear me?
Yes, we hear you are clear.
You can hear me now, yeah? Okay. So thank you very much for inviting me to present this on today's. You hear me? Hello? Okay, that's fine. So I think without wasting time,
Yes,
I chose this topic.
yeah, we can proceed.
I chose this topic, chest pain, because it's one of those common presentations in our acute medical admission unit and also in the accident and emergency departments. Just as a brief introduction, we know that chest pain in the US, based on the previous data, led to 7.6 billion attendances, but this is now more than that because most of the patients who come to the ED, many of them have chest pain. And of course, with the lifestyle changes, we are getting lots of acute myocardial infarctions in patients in younger age because of our lifestyles. So that's the increased number of chest pain presentations. In this chest pain, we know that signs and symptoms might reflect the many potential etiologies of chest pain, as we shall be able to see that in our presentation later. And what's important is that clinicians in the ED focus on immediate recognition and exclusion of the life-threatening causes of chest pain, because we have various presentations. Some of them are life-threatening, some of them are just simple. So a physician should be, or an emergency doctor should be able to identify which is the life-threatening and initiate the appropriate management. And of course, patients with life-threatening etiologies for the chest pain may appear deceptively well, as we shall see later. So diseases of the heart, the major vessels, the lungs, the esophagus, stomach, mediastinum, pleura, and abdomen may all cause chest pain. This is what we need to understand. And patients may present with what looks like abdominal pain, but in actual sense, may be having a heart attack. So it's very important that you obtain a good detailed history, physical examination, which is supplemented by the investigation to come up with the final diagnosis. So the aims of this presentation today is at least to get a good history of chest pain, formulate a differential diagnosis, and initiate an appropriate management plan, and furthermore, refer to the appropriate subspecialty. So if we begin with the chest pain, what's important is in the medical school, we use say, oh, chest pain. You need to describe its onset. Is it acute or is it going on for some time? For how long has it been going on? You need to say, identify what's the severity of this pain. I have said that it's something that looks like severe, may not be severe to other patients, so it depends on the pain thresholds of whoever is presenting. We also need to describe its radiation, its character, what makes it worse and what makes this pain better, and are there any associated factors with this chest pain? For example, has he got a fever, or has he got shortness of breath, or has he got cough? Based on those, you may be able to come up with a diagnosis. And you need also to establish has this patient ever had similar presentations in the past, and also any other relevant family history and private drug history. So I normally start my presentation with the conundrums, and the conundrum here normally is it's a brief presentation of a presentation something. Whoever gets the diagnosis gets a prize. Normally I tend to give about £50 for the prize. However, because we are an audience, whoever able to get this prize, probably we might donate it to the Busoga Healthy Foundation. So this is the conundrum. Before I start this presentation is going to be mainly case-based presentation, so that you can understand and you need to be involved in these presentations at least, so that I engage you. So this is a guy I saw in Scotland. This is about 5 years ago. 58-year-old electrical engineer with a history of depression. He presented with personality change and a dry cough. However, 4 weeks prior to his presentation, he had been admitted with paracetamol overdose, which we treated very well and improved. And at the time, he also, actually it's not 5, but 3 years ago, he also had a symptomatic COVID-19 infection at the time. His biochemistry was normal. He had white cell count just marginally raised. A chest X-ray is shown. Can anybody tell me what's the diagnosis? You can just shout it because I can't see you guys. Anybody in the audience? Hello? You can see that slide?
Like biliary tuberculosis.
So somebody thinks it's pulmonary tuberculosis. Unfortunately, it's not.
Biliary tuberculosis.
No, that's wrong.
Fibrosis.
Sorry?
I can see where are they opacities? Can see they are homogeneous opacities,
Yeah.
which could be pneumonia caused by COVID-19.
Okay, unfortunately, it's not. We need to win this money for the foundation, guys. He's an electrical engineer. That's the clue.
I guess pneumocystis carinii.
No. We proceed. Do you want to know the diagnosis?
Chance for Kenya, Mwangi, shortly after coming on. Probably could have done a little bit better with that one.
Pneumoconiosis.
We proceed.
Atypical pneumonia.
Okay.
Fibrosing alveolitis.
It's likely to be asbestosis.
Unfortunately, no. So, without wasting time, that's the diagnosis: mercury poisoning. So this guy, he had depression, and initially he had paracetamol overdose. So when we discharged him, he's an electrical engineer. He had access to these valves, these long valves that contained mercury. So he was drinking mercury as he overdosed. So when we did the chest X-ray, that's what we found. And on further inquiry, That's it. So you can see what you think. There's a lot of matter in his stomach, in his left ventricle, in the lungs, and things like that. So I put in COVID pneumonia, COVID infection just to confuse you, to bias you. But he not had any COVID. So I was just trying to bias you. So he had mercury poisoning. So we referred him to Birmingham, where they tried to suck out mercury from his left ventricle, from the stomach. Unfortunately, he died. And even cremation was a problem because of the environment issues. But thankfully, it ended up successful. Okay, so we can proceed to our major presentation. So this is, as I said, it's going to be a case-based presentation. So 55-year-old man admitted to accident emergency with a collapse. He was seen by the consultant in the ED, and he was thought to have alcohol seizure. This gentleman had had previous seizures anyway in the past because of alcohol. So he was treated with the Fabrinex, this is a multivitamin which contains thiamine, and he was referred to me at that time because I was the registrar on call. And when I took further history, this man said that, doctor, I did not have a seizure at all. I've had seizures in the past, but this was not a seizure. So, however, this man was feeling dizzy, especially on standing, and on the day of admission, he had a left-sided chest pain. Okay. On general examination, it was normal. His saturation was 97 on room air. He had a respiratory rate of 20. The only abnormality with him was a tachycardia of 115. He, however, had a normal blood pressure, and temperature was normal, and his blood sugar was normal. Chest and respiratory examination was unremarkable. CNS was grossly normal, and abdomen was normal. Any thoughts? So this man had, when you have such types of history, you need to think, could this be cardiac? Because he has chest pain and he's tachycardic. He had what looked like sinus tachycardia. Could it be acute coronary syndrome or arrhythmias? Could this be pulmonary embolism or pneumothorax? This man had what was collapse. Could it have been a vasovagal syncope? The fact that he's diabetic, could it have been hypoglycemic? Or could it still be alcohol seizure? So basically, those are the possible differentials in this man. But of course, with the proper history, you can narrow down the diagnosis. The investigation we did, he had low platelets, 48 with MCV 101. This is expected in patients with chronic alcohol intake. And his biochemistry was hyponatremic. This is also expected in patients with chronic alcohol intake. His LFTs were normal other than just marginally raised bilirubin, which is not that much concern. Those were his arterial blood gases on room air. His PO2 was 8, and PCO2 was 3.3. That means he was probably hyperventilating to blow out the PCO2. His chest X-ray was normal, and that was his ECG. Can anybody point out what you can see on this ECG? Any idea?
There is no P-wave.
Sorry?
There is no P-wave.
There's no P-wave. Actually, if you look properly in lead 2, you can get some few P-wave, but I know that it's quite maybe difficult to visualize. But if there's no P-wave, that means somebody is in atrial fibrillation anyway. But I think what's obvious is that it's got a tachycardia, as you can see. It's got a sinus tachycardia. And if you look in lead 1, it's got deep S waves in lead 1. And if you go to lead 3, it's got T wave inversion in lead 3. And also it's got what looks like Q waves, which we call S1, Q3, T3, which we see in patients with the pulmonary embolism. The commonest presentation ECG manifestation of pulmonary embolism is anyway sinus tachycardia. So you rarely see this ECG, which is S1, Q3, T3. So this patient had pulmonary embolism. If you look at this CT, you can see the pulmonary vasculature. You see that, are you able to see the arrow I'm pointing at? It's got a filling defect. So there is no contrast. Whatever you are seeing white in that pulmonary trunk, there is opacification, but as you go bilaterally, especially on the left, you can see that the contrast is not able to go through. So that means this guy had pulmonary embolism. So one of the common presentations of pulmonary embolism is collapse or syncope. So the diagnosis was pulmonary embolism, but you might be biased when a patient is a recurrent or a regular attendant in your department with seizure. So you may be biased and say, oh, this patient had seizure, but he may have something new. So he had pulmonary embolism as the reason for his collapse. And the one, of course, presentation of pulmonary embolism on ECG is sinus tachycardia. That's why you saw his heart rate was 115. His PO2 was low, it was 8, that is low. And his PCO2 was low, he was trying to blow air. So the final diagnosis was PE. Management, of course, you need to consider the A, B, C, D, make sure the airway, breathing is okay, circulation, and any disabilities, and then you need to evaluate that for E. So the definitive management in this patient, of course, is anticoagulants. If a patient is hemodynamically compromised, low BP, very much collapse, raised troponin, which is troponin is a cardiac marker for myocardial injury, and also right ventricle dilatation, treatment will be thrombolysis. And if the patient is unstable, as I said, with sudden BP, right strain and raised troponin. In fact, when we did his blood, CD dimers, as you can see, were very, very high. So the final diagnosis was PE. Any question regarding that case? If not, we can proceed. Another case was a 70-year-old man. He's had previous PE. He presented with dizziness and collapse. He had stopped his warfarin at the time. This is a guy I saw in 2017. So he also had shortness of breath, but did not have chest pain. His observations were stable and the chest was clear. So the investigation, we did the D-dimers, which was significantly high, as you can see, in tens of thousands. Chest X-ray was normal. His ECG was showing sinus, but with Q waves, and CT piercing also. As you can see on that side, also contrast should be white in those vessels in the pulmonary vasculature. But you can see that they are filling defects, which is looking like a black. So those are filling defects. So that means this patient has also PE. So the next case is a 45-year-old Asian man. He presented with vomiting and indigestion and epigastric pain with no chest pain. He had a past medical history of hypertension and he was type 2 diabetes with high cholesterol. Those were the medications he was on. He was taking statins, beta blocker and metformin, and also aspirin. And he was a current smoker of 20 cigarettes a day. He had a strong family history of ischemic heart disease. At that time when we assessed this man, he looked comfortable and relaxed. examination other than the tachycardia of 108, his saturation was normal and respiratory rate was fine. The systemic examination and abdominal examination were unremarkable. So those were his bloods. His white cell counts was 13, and with a marginally raised neutrophil 9.8, no MCV. As you can see, all his biochemistry was normal. He has just marginally raised amylase 108. He had an erect chest X-ray and abdomen X-ray, all were normal. So that was his ECG. Any thoughts about this ECG? So as you can see, this is a sinus in AVL, which they tend to reflect the lateral. There's some T-wave inversion anywhere, but other than that, there's nothing else abnormal that I could see on that ECG. So my colleague who saw this patient, he was one of the junior doctors, he made a diagnosis of gastritis or dyspepsia, and he had this excellent plan: omeprazole and antiemetics and paracetamol, and then he said this patient will be followed up by his GP in the community and advised to return if further pains are worse. So as this man was preparing to go home, he developed further discomfort and he vomited. He became clammy. He looked pepper white. His repeat observations, as you can see, the blood pressure was lowish, but it was bradycardic with the heart rate of 45. The rest of the observations were normal. We did a repeat ECG, so anybody can see the difference between the previous ECG and this current ECG. Anybody able to point out that? Any volunteer?
We are not seeing the ECG.
Sorry? You can't see it?
I think on lead 3 and lead
segment
AVF, there are obvious ST segment elevations.
Yes.
ST segment in the wall.
Okay. So it's got lateral T-wave, lateral ischemia, and then you can see it's got ST elevation in the inferior leads. That is lead 2, 3, and AVF. This try to be consistent with the right common artery ischemia. So as you can see, initially presented what was this thought dyspeptic symptoms, which is very common in the young Asian community. They tend to present with dyspepsia or gastritis. So always be very, very careful in the young Asian community. I know that there are plenty of Asians now in Uganda, and always be careful when you have these types of patients. And they tend to have myocardial infarction at a young age due to a genetic predisposition. And also, he had these risk factors: hypertension, high cholesterol, diabetes, and he was a heavy smoker. So he had an inferior STEMI or inferior ST elevation myocardial infarction. So that was the diagnosis. So treatment for this, again, before we go to that, I'll come back to that same case. I give you another scenario of a 72-year-old female with hypertension. She had left-sided chest pain, dull and radiated to the jaw. This is quite textbook work of myocardial infarction or heart attack presenting angina presenting to the jaw or the left arm. She had shortness of breath but no cough, and she was an ex-smoker and no family history of ischemic heart disease. On examination, she looked diaphoretic, very sweaty, hypotensive, as you can see. She had raised JVP. She had bilateral crepitations. troponin was raised. The troponin of 50 is raised. Normal should be upper less than 5 high sensitive troponin. This is a marker of a biomarker of myocardial injury. So electrolytes were normal. That was the ECG. Can anybody tell me what you can see and where is the problem on this ECG?
I think there is the ST segment depression on the septal leads V3, V4.
Right.
Posterior MI.
Brilliant. This is a posterior MI. So if you want a posterior MI, you get ST depression in V2, V3, around V4. When you turn this paper upside down, the ECG, and you look through, it looked like ST elevation. So this patient had a posterior MI. That was the diagnosis. So you can see that this lady presented completely different from the other Asian man, okay? And that was her chest X-ray, which was showing acute primary edema, which can be a presentation of an acute MI. You can see fluid in the fissure, bilateral upper lobe diversion, and interstitial changes bilaterally. So that was acute MI with acute primary edema, okay? So in these two patients who present with acute MI or any STEMI, whichever, the mainstay is still the ABCD principle. Make sure you resuscitate this patient before you go to the definitive management. Of course, definitive management, you need to give initially high dose aspirin and high dose clopidogrel or Plavix, and then heparin, GTN if the patient has got chest pain. You may give beta blockers, but you need to be very careful. Somebody with acute cardiac failure, you need to avoid beta blockers because it may worsen heart failure. And of course, ACE inhibitors. Give morphine and diuretics to relieve the pain. CPAP is now no longer advisor because they don't think there's any much benefit in giving people CPAP, but you can give them high flow oxygen. And of course, you need to admit this patient in coronary care unit, involve the cardiologist as early as possible for the definitive management. Definitive treatment is PCI. You need to stent this patient, but at times if the patient comes late, when they've already developed Q waves, the immediate PCI may not benefit. There are some centers across wherever around Europe and in my place where I work, where they do thrombolysis, like outplays or streptokinase, whereby this is the aim of this is trying and open up the vessels. In most cases, you may not get 100% recolonization of the blocked vessel. So ultimately, this patient may later require PCI. So this lady, she had primary PCI to her circumflex that was performed, and that was the outcome. So this picture was, the reason I brought up this picture, I'm sure you know the person holding the silver, that's the great Roger Federer. Then we have the Andy Murray, and then this Argentina guy, I can't remember his name. So all along, when Andy Murray was playing Federer, it was known that Federer is going to win. But this time, Andy Murray won and won this Olympic gold. So what I'm trying to say is that not every time that patient with myocardial infarction will present the same way. They present differently. They present a typical presentation. And patients with diabetes, they may not have pain at all, which is common. So they may have a silent MI. Case number 3 is also a guy I saw in 2014. This guy was a 40-year-old man who had a recent travel to Singapore 3 weeks prior to the presentation. He had central chest pain that was not related with exertion or chest pain. He had a dry cough with a sore throat and a low-grade fever. He had previous presentation 10 years ago, and his doctor prescribed him GTN, which is the glycerine trinitrate, to try, and we commonly give it, as you know, for angina pain. Although this man had not used it for about 10 years, he had no cardiovascular risk factors. When he was examined, everything looked normal, as you can see, except he had what the junior doctor thought, oh, he had a systolic murmur, but his heart sounds were normal and JVP was not raised. I'll tell you what I found when I examined what the junior doctor called a systolic murmur. So, any idea? So, those were his investigations. Marginal raised white cell count, CRP also marginal raised. Troponin was normal, which is as I said, a mark of myocardial injury. So there was no evidence that this patient had a myocardial infarction or any STEMI. And we normally repeat troponin 12 hours from the time he had chest pain, and it was again less than 0.05. The rest of his biochemistry was normal. So chest X-ray only showed a slight cardiomegaly. And that time he was treated as ACS by the ED doctors and referred to the cardiology. And that was his ECG. Any thoughts? What do you think about that ECG?
Chest leads V2, V3, V4.
Sorry, S what? So what do you think is the diagnosis in this man?
Ronald says rheumatic heart disease in the chat.
No, not really. So what you can see is got diffuse ST changes almost in all leads. You agree? You look at lead 2, lead 1, V4, V5, V6. So it's got this widespread ST changes. So the diagnosis is acute pericarditis. So what you can see in the dose, there is what they call saddling. Okay. So it looks like some form of saddling, which may look like ST elevation. You can well see it in V4, V5, V6, and also in V1 and V3. This is what we call saddling. So this guy had in the past what the clue here, he had a recent chest infection, what looked like a sore throat. So we get pericarditis, especially after a recent upper respiratory tract infection. So they may present with acute chest pain, and then when you do the ECG, it shows what looks like ST elevation, but that is saddling. So what the doctor had, what he called a murmur, was actually a pericardial rub. When I listened, this guy had a pericardial rub. Okay, so that's acute pericarditis, and he had some cardiomegaly. One of the complications of acute pericarditis, you can get a pericardial effusion. And again, we know that pericarditis tend to be recurrent. That's why this man, 10 years ago, he had similar presentation. And that's why he presented again. So it tends to be recurrent. So treatment again is A, B, C, D, E. Make sure the patient is stabilized. give high dose aspirin or NSAIDs with the PPI cover. Colchicine is given for prophylaxis to prevent recurrent pericarditis. So that's the drug of choice. And make sure you do an echocardiogram prior to discharge, because these guys may be complicated with a pericardial effusion, they may go into cardiac tamponade, which can be catastrophic. So always an echocardiogram before discharge. That was the chest X-ray. You can see at cardiomegaly, which looked globular, and also there was some fluid in that. Okay, that is a CT. You can see fluid around the pericardium, encircling the heart. So it's important that you can, when they did echo, you can do echo or CT. When they did CT, that's what they found. So we can move to another case in the interest of time. A 23-year-old girl. This was some girl in the north of Scotland. Again, she was inactive IVDU. She presented with right chest pain with a cough that was rusty for the past 24 hours. As you can see, she had a pyrexia and a rash. She had also a swollen left calf. Examination, she was pyrexia. She had needle track marks because she was an IVDU and this non-specific rash. You can see her observation, she was hypoxic because her SATs 88% of room air. She had respiratory rate quite high and she was hypotensive. Tachycardic, her GCS was 14. Chest, she had bilateral crepitation and CVS was normal. What do you think is the diagnosis here?
A PE.
Sorry?
A PE.
PE could be possible, especially septic, because she's an IVDU, so she could have septic pulmonary emboli.
Endocarditis.
That's a differential.
Effective endocarditis.
Effective endocarditis.
Endocarditis.
Right, she could have effective endocarditis, but this could be confirmed on echocardiogram. Any other diagnosis you think?
Pneumonia. Pneumococcal pneumonia.
Sorry? Sorry, I can't hear. So you can see that she was hypotensive. So she looked septic. She had what looked like multi-organ failure. Okay. So she's definitely septic, this lady. Pyrexia, she got hypotension, tachycardic, reduced GCS. So in the SOFA score, she scores high, but examination had bilateral crepitations. CVS was actually normal. So those were the bloods. White cell count was raised with a very high urea, and she had also AKI with raised urea and creatinine. Her ABG, she was hypoxic. She was in type 1 respiratory failure, ECG, sinus tachycardia, and we sent blood cultures, and that was her chest X-ray. What do you think about that X-ray? So, in the interest of time,
dextrocardia what?
bilateral consolidation. She's got, you can see an air bronchogram. You don't know whether if the arrows are. So she's got bilateral pneumonia. But the question is this
That one looks to be like a bronchopneumonia with the
So those are some of the
an adenoma in the left.
So I didn't hear. So the diagnosis was community-acquired pneumonia. She had a pneumonia, she was pyrexia, she was having a rusty cough. So rusted sputum, coffee brown, sorry, not coffee brown, but brown in color. So management again is the ABCD. Don't forget this ABCD principle. So at that time, because she was very septic, she was catheterized, she had blood cultures sent. We assessed the prognosis based on CAP score. Her CAP score was high. She had a CAP score, she was confused, that score was 1. Urea was raised, that score was another 1. Respiratory rate was 30, that's 1. She was bradycardia, so hypotensive, so that's 4 already. And she's not 65. So she had a CAP score of 4, of which this was severe pneumonia. At times, the other way you can score that, the severity index, pneumonia severity index, but CAP score is quite good. I use it to decide whether I should discharge the patient. If a patient has got a CAP score of 0, I don't need to admit this patient. This patient can be managed as outpatient. But if CAP score 2 or above, then you can say, okay, it's better to admit this patient. So she got the fluids, antibiotics, and oxygen, and we admitted her in ITU. And of course, being an IVDU, that's intravenous drug abuser, don't forget always to look for blood-borne virus screen, HIV, hepatitis B and C, and the rest. So could it be a possible PE? The answer is yes. One of you said, could it be PE? Especially if a septic primary emboli, the X-ray can be in that form. Do you think the D-dimer would be of any help when you have such an abnormal X-ray? We expect the D-dimers to be high. So it would be a wastage of resources to do a D-dimer in this patient because we expect it to be high anyway. And what other investigation would you consider to exclude PE in this patient? Prior CTPA, things like that. Case number 5, this is a 53-year-old man, hypertensive and had a previous MI, heavy smoker of 40 cigarettes for the past 30 years. He was on those medications, as you can see. He had a 24-hour history of severe central chest pain. It wasn't aggravated by anything. His pain score was 10, actually. He said, my pain is 10 and above. On examination, he looked really very restless, this man. He looked pale and was sweating. His blood pressure was a little bit high, chest was clear, and his abdomen was normal. Blast down to exclude any abnormal, sorry, to exclude NMI, he had normal, but the troponin was 15. So as I said earlier, troponin now 15, that means it's slightly raised. That means there's maybe some myocardial injury. And that was the ECG. Without wasting time, I think the ECG isn't much other than some T-wave inversion in AVL, but other than that, really not much. Maybe prior the laterally, you may have non-specific T-wave changes, but nothing much significant. And that was the chest X-ray. Can anybody comment on that X-ray?
I think there is a widening of the mediastinum, possibly an aortic dissection.
Yeah, that's right. There is widening of the mediastinum. So that's right. That was the CT aortogram. You can see the dissection, the aortic dissection. You can see there. Are you able to see it on the CT? There's contrast there in the aorta, but again with that black concave, sorry, crescent appearance. I don't know that if are you able to see it when I move the arrow, or you can't see? You can see the aorta, yeah?
Yes, we can see. We can see the arrow.
So the diagnosis was actually a dissection. When you get somebody with the pain, which is disproportionate with how he is, and is hypertensive, marginally raised troponin, non-specific ECG changes, an aortic dissection has to come into your mind. Again, as you can see, there's that dissection in that CT imaging. So we have type A and type B. So each one of these have got different management. Type A, it starts from there, as you can see. And then we have that. Sorry. So management is again ABC. Control the pain. We have medical management. If it's a descending aorta, control the pain. And then the surgical management, it is ascending. So basically, that's the way you can manage, but always have it in your mind about the dissection. And another one, a 35-year-old man, non-heavy smoker, presented with ED with a right-sided chest pain, shortness of breath, and a dry cough. He had no fever, and he was usually fit and well. So look at, is a 35-year-old and heavy smoker, sudden right-sided chest pain, shortness of breath, and a dry cough. Any differentials? That was his observation. He looked very tall, breathless, tachycardic, and a little bit hypoxic. His chest was hyperresonant. So I'm sure you have the diagnosis already, and ECG was sinus tachy. So what's the diagnosis here?
Tension pneumothorax.
Exactly. So he had a pneumothorax. So you can see he had a collapsed lung. You can see on the right side, he had a collapsed lung. So it's got a massive pneumothorax. So he's a smoker and tall. So he had some maphanoid features. So it's important you examine these patients. We commonly see many patients with maphoid syndrome here with the classical textbook description, and they are presenting with the pneumothorax. So what's important is to identify the pneumothorax and then take the necessary treatment. That was a spontaneous pneumothorax. Management, again, I'll stress the ABCD. Aspirational chest drain. Depends if it's we know if it's primary pneumothorax, that means it's occurring in a patient without any abnormal lung abnormalities. Secondary, we know that the patient probably has some abnormalities in his lungs already. So that's what differentiates the two. And of course, management, it depends on the British thorax guidelines or the American guidelines for the management, so the classification. So what's important, the definite management, if it's symptomatic, or before we got that, if it's a pneumothorax 2 centimeters or less, when you measure the thickness of the pneumothorax, you can do symptomatic management. If it's not breathless and is asymptomatic, you can discharge this patient with advice. So if he has 2 centimeters or more and is breathless, you can try to do a needle aspiration. But if things don't improve, then you need to do a chest drain. And don't forget to advise them smoking cessation, because if they smoke further, there's a likelihood of recurrence of this pneumothorax. And advise them to avoid scuba diving, and they shouldn't fly. Ideally, it should be for 6 weeks. That's the advice we normally provide these patients, because if they fly, the likelihood of having another pneumothorax while flying is very high. And they, as I said, they shouldn't do scuba diving. I think we are running a little bit, but that's fine. We still have some maybe 10 minutes. 35-year-old businessman who was a frequent traveler across the globe. I met this gentleman about 8 years ago. So he had multiple sexual partners. He had a right-sided severe chest pain. His clinical examination was otherwise completely normal. His ECG, chest X-ray was normal. Bloods, including the troponin and screen for PE, were completely normal. This man was in such a very, very severe pain, and we had to give him morphine repeatedly because of the severe pain. So what goes in your mind as a possible diagnosis in this man? Could it still be PE because it's a frequent traveler? You can have PE anyway, and with normal D dimers, but if you do the Weil score or the screen test for PE, this score would be low.
One in the chat says PE from Nalaidema.
Sorry. Any thoughts? So, 6 hours later, when in the department, a rash was noted over his right chest wall. That was the rash. So do you have the answer now, don't you?
Shingles, happy
Yes.
zost.
Any question? Exactly. So this man was in such severe pain. Now, I remember when I was in Mulago, we used to see this patient with severe chest pain. And a few hours later, you see this guy has developed shingles. So the pain can be very, very severe. And so he had multiple sexual partners, he was a frequent traveler. So this man ended up having immune suppression. So the diagnosis is pre-herpetic chest pain. So he received analgesia, antiviral, and he was referred to ID. We did his his HIV test, it was positive. But as I said, remember also to screen other bloodborne viruses and STDs. And of course, don't forget conditions like a gastroesophageal reflux disease, patient with pain, costochondritis, muscular chest pain, esophageal spasm, and just remember that a patient with esophageal spasm, which we normally describe as a nutcracker esophagus, they respond to GTN. So you may confuse this esophageal spasm with angina. Okay. Any questions? I think that might be the end of my slide presentation.
Yes, over to Dr. Kabweru Wilberforce to lead us in the Q&A.
Thank you very much, Dr. Isabirye. I want just to ask some people to ask some questions. This has been one of the most interesting, very academic session for most of the people who have not been in the ECG echo room and who have not been in the radiology, enjoying CT and CT angio. I think today had a very different, interesting teaching, but it was quite very educative. But so many people were very interactive, which was I was listening in and enjoying the interaction. Thank you very much, Dr. Isabirye. So I want people to raise up their hands and ask Dr. Isabirye some good questions. He has given us a number of cases that are very interesting, well diagnosed. They have a lot of diagnostics and well investigated. Obviously, objectively, I would say, not doing unnecessary investigation, but specific investigations that were targeted or focused. So anyone with any questions, raise up your hand. Yes, Dr. Ivan Magale, can you ask your Ivan, please unmute and ask your question.
Yes, thank you so much, Dr. Isabirye, for the wonderful presentation. Very informative. My question is, looks like you're presenting from, okay. I have unmuted. Can I be heard?
Yeah, you heard. Continue.
Yes, now I can hear you.
Can I be heard? I have unmuted.
Yes, continue, please. We can hear you. Just continue.
Yes, go ahead.
I have unmuted. Can I be heard?
Doctor, go ahead. We are hearing you.
I have unmuted.
We can hear you. We can hear you.
Okay. So I was
Is he there?
Oh, it seems Ivan is dropped off. Can we have another person ask his question? When is back?
I can't hear him.
Benjamin, meanwhile, please hear the CPD interacting with, so that they don't whatever of the network seems to be shaky. So, the other question is, have we understood nothing or have we understood everything? But it was quite, yes. Peter Kivunike, ask your question, unmute and ask Doctor your question.
I have this.
okay. I
Yeah,
think
thank
I
you.
am back. Can I be heard now?
Yes.
Peter, go ahead. After Peter, then Ivan will rejoin.
Okay, thank you, Wilberforce, and happy to be here. Claret, happy again to connect here.
Okay. If I can be heard, my quick question was about that it is common in research. Yes, hello? Can I ask my question?
Ask your question.
Yes.
We are hearing you.
Yes, go ahead, please.
Okay, since we can't hear Ivan, let's hear from
Is
Peter.
it
Peter, go ahead and ask
maybe
your question.
you have my email?
Hello, Wilberforce, can I go ahead? Can I go ahead?
Kindly go ahead and ask your question.
Can I go ahead now?
Kindly go ahead and ask your question. Go ahead.
Okay, thank you so much. And I was saying thank you so much, Wilberforce. And Claret, thank you again to see you here after so many years, after having worked together in Buluva Hospital quite a number of years ago. What I wanted to know from you is that you are in the UK, but I want you to give us some tips on the diagnosis of chest pain, especially if I'm looking at a doctor or a health worker who is in a health center 4, somewhere in my village there in Kaliro, let's say Umanya Health Center 4. What tips can you give us, you know, vis-a-vis the capacity to do, not to do those investigations you have highlighted? Thank you, and over.
Thank you for that question. Can we have Peter Nason ask also?
Good evening. This is really a very good session. I have had a lot of the case presentation, and mine is just an insight into, based on his experience, the presenter, what is his take about the, like in my facilities where I'm practicing now, we have an ECG machine which interprets automatically the ECG. However, I don't know how do we really need to believe into the interpretation in most of these machines. Have I been heard?
You said machine interpretation. Which machine?
BHF, have I been heard?
Yes. Loud and clear.
Can you repeat your question?
Yeah, we have the ECG machine, and these machines can read for you and interpret for you the findings. However, it is, to me, I still need to the clarification about how should we really take wholeheartedly that this interpretation is right, or we really need the personal skills on how to interpret this so that we can have the better judgment of the findings.
Oh, thank you very much for that question. And also, I think I have one question related to this. Our setting here, what we call either lack of or inadequate resources. And some of the diagnostics actually are not readily available. And if they are available, they are costly. So we are still held between a hard rock and a very rough surface. And this actually impinges a lot on service delivery, even training, and then even research. So what would be your advice as we are still working in this low resource setting? Over to you, Dr. Isabirye. You can take up those three.
Okay, I think let me slot in mine. I failed to slot in before.
Oh, that's okay, Ivan.
Okay, yeah. So mine is also in a context of resource limited. It is common for even hospitals in Kampala, where there are better resources, to only have an ECG machine, but not have the blood tests like the troponins. Sometimes even when they can afford, but because in terms of business, it doesn't make sense to stock reagents that are going to expire because you have few patients. But a good thing with a machine, ECG, you can have it as long as, even if you're not using it. Okay, so the question is, of these two tests, the troponins and ECG, which one is good, especially in the early stages of an MI? Or would I miss anything if I have this patient that presents with symptoms of an MI, I do an ECG, and the ECG is essentially normal? Should I worry that because I have not done troponins, because the lab where I am has not stocked reagents for troponins, I have missed out something? Maybe the troponin would have seen what the ECG has not seen. Yeah, so that's my question. Thank you.
Okay. Any more questions?
Internet.
Then
Doctor, you can continue with those. We don't have any hands up.
Okay. Let me start with the last question, whereby whether troponin. I know that there are many places. I don't know that, but I had an impression that there is troponin test in Uganda. Until when I was interviewing some doctor recently for a job, he told me that they don't have troponin, and the doctor hadn't known what troponin is anyway. So there is what we call NSTEMI, which is non-ST elevation MI, and also we have STEMI, which is ST elevation MI. So non-STEMI, which is non-ST elevation MI, the troponin will be high usually, and when you repeat it will be rising. With any STEMI, the ECG will in most cases be normal. That's why it's called non-ST elevation MI. Whereas with the STEMI, which is ST elevation MI, the ECG is very, very resourceful and very useful. But of course, you need to know how to interpret the ECG. I remember we had a professor, the late Professor Mkota, rest in peace. He used to tell us that the eye sees what it knows. You might look at an ECG with ST elevation, but you don't know that is ST elevation. So ST elevation is, ACG can be one of those difficult interpretation investigation. So to answer your question, to me, troponin is good, and it's trying to be very specific, although we may get troponin rise in some conditions, like a CKD, even PE, and even sepsis, you can get troponin rise. But if you take a good history, chest pain, and it's got risk factors of coronary artery disease, then you are able to make that diagnosis. But as I said, both tests complement each other, the ECG and the troponin. If the ECG is normal, that doesn't mean that this patient has not had an MI. That's why we call it non-ST elevation MI. I don't know if that is clear. There are some places still in some centers where they do what they call CKMB, creatine kinase myoglobin. If this is raised and the patient has got chest pain, there are some centers that are using that screen, especially in a very busy emergency department. But this is something that we've not used where I practice. We've not used it for a long time. But if you are stuck and you do the CKMB and it's raised, then the chances are high that this could be an MI. So that is, and I'm sure we have CKMB in many laboratories in Uganda. And of course, as I said, history is the main tool for making a diagnosis. History and clinical examination, very, very important. The question to machines interpretation like ECG can interpret for you, be careful. Some of the ECGs, the machines, they are giving you wrong interpretation. You may get an ECG with lots of ectopics, for example, but the ECG interprets wrongly. So be very careful. I suspect that you may just need maybe a session on how to interpret the ECG. I don't know I don't know whether on the forum whether we have any cardiologists who can help that out. I know there are other physicians who can help out. I'm happy to be involved at some point, but ECG interpretation is something that really tend to tease many people. And of course, you talked about the inadequate resources. As I said earlier, if you don't have troponin, go ahead and do LFTs. Many years ago, patients who had myocardial infarction, their LFTs were abnormal, white cell count was raised, and CRP was raised. Even now, we get patients with raised CRP, raised white cell count, and abnormal LFTs. But this is not a substitute for troponin. We have troponin high sensitive, troponin I, and then troponin T. We tend to go for troponin I, so troponin T, which is quite sensitive and specific. And then somebody talked about if you're in a health center for, how would you be able to make a diagnosis of this or chest pain, whatever is causing. But as I said, I can understand the difficulty, because if you go even to big referral hospital, you might find that there are no resources to make some of those investigations. So again, history and clinical examination is very important. At least every place should be able to have an ECG machine to be able to interpret the finding on the ECG. So somebody who is in Ibuwenge or Luka Health Center, have somebody with chest pain, take a good history. Has he got risk factors? Then do a clinical examination, and then you can have an idea. And I know, of course, you may not have the capability of managing this patient there. So you just need to make sure that you refer the patient. But I know that the resources may not be there, but that's the way the system is.
Okay. Dr. Kabweru,
Okay, thank you
would you
very
consider
much,
the end?
Dr. Isabirye. Yes, we want to. I want to ask Dr. Peter Kawanguzi to give a vote of thanks if to Dr. Isabirye. Is Dr. Peter Kawanguzi on the call?
Yes, Dr. Kabweru, I am. Thank you so much for giving me the privilege to give a vote of thanks. Dr. Isabirye, first of all, I want to thank you for flying our flag high where you are. It really boosts our morale to know that one of our own is out there representing. So we thank you so much for that. We want to also thank you that despite being out there, you're coming back to give back to society by giving us some bit of cutting edge presentations that have been so illustrative. Over the years, you've kept your slides well. You've discussed the topic right across the board. And I'm sure everybody who has attended will go back a little bit wiser. For that, we want to thank you so much. And we hope that you will not tire, basically liaising with the Busoga Health Forum, because our region really, when you look at it, is one of the regions that is really taken a beating over the last 2-3 decades. Each one of us in our own cocoons really matters. We have to contribute if we are going to pull the region out of the abyss in which we find it. So thank you so much, Doctor. Thank you so much, participants. And thank you so much, the forum, for enlightening our people. Have a good night. Thank you so much, Dr. Kabweru.
You're most welcome, and thank you very much, everybody. May God bless you until next week when you join us on Busoga Youth Forum. Doctor, we shall miss you very much, but also thank you for joining us when we are writing the curriculum for medical school. May God bless you.
Bless you. Thank you very much. And it's been a pleasure to interact with you guys. I'll always be available when required. And I think Ben has my email. So if you have any more further questions, that's fine. I'm happy to share these slides with you for just learning purposes. So if you want, I can send them to you for more, because I know it was a little bit quick with interruption of internet and things like that. So I'm happy to forward these slides to you guys.
Yeah, so thank you so much, Doctor. The slides will be uploaded on our website, and the recording of this session will also be uploaded on our YouTube channel for reference. Participants, today we just here to use out of the code to bring to this presentation. But as Busoga is from, we shall never fail to give you a presentation in all ways. Thank you so much for attending. Have a nice weekend.
Okay. Thank you very much.
Okay, bye-bye, everybody. May God bless you all for God and my country.